Deepak Barathi from the Department of Radio Diagnosis at JIPMER, Puducherry. I will be speaking about our experience in establishing PACS in JIPMER. Before talking about our experience, I would be talking in general about PACS. PACS is an acronym and it refers to Picture Archiving and Communication System. And it is a physical computer network which provides for economical storage, convenient access to images from multiple modalities. Now, the most important stress is to be given to economical storage and convenient access, and also to images from multiple modalities. The problem about archiving and accessing images from multiple modalities was due to the fact that image formatting was different for each vendor, and because of that, viewing images from multiple vendors simultaneously was a big challenge. We'll come to how it was solved later. So, in the acronym, the letter P refers to picture and it refers to the digital medical image. And so, digitization of the medical images is a primary requisite for establishing a PACS. And A stands for archiving, and this refers to the electronic storage of images in servers and hard disks. And C refers to communication, that is the routing, retrieval or sending and displaying of the images, and this happens through the local area network available in the hospital. And S stands for system, which refers to the specialized computer network that manages the entire thing. Now, as I already told, the digital image is the basis of the PACS, and for that, the digital image should conform to the DICOM standard. Initially, each vendor had an image format unique to the vendor, and it was very difficult to view all these multiple modalities simultaneously in the PACS. For this reason, DICOM was introduced. This refers to digital imaging and communication in medicine. That is the expansion of DICOM. DICOM is the international standard to communicate and manage medical images and data. Its mission is to ensure interoperability so that images from different vendors can easily be seen simultaneously within the PACS. So production, storage, sharing, as well as all related workflows are easily managed if the image corresponds to a DICOM standard. So it is the universal format for PACS image storage and transfer. So without DICOM, it is not possible to establish a PACS. And a PACS can accept any image that is in the DICOM format, whether it is irrespective of the source of the image, whether it's a CT image or an ultrasound image, whether it's from radiology or cardiology. We can even make DICOM images from endoscopic images and pathology slides. So all these can be stored in the PACS in an easy manner. But before storage, each modality has to be first configured to the PACS, then it can interact with the PACS and send and receive images. Now the PACS doesn't work alone, it has to work along with the hospital information system. The hospital information system holds all the patient's information, full medical information from billing to inpatient order system, the electronic medical record, and this provides for why does the PACS have to interact with the HIS? The PACS receives the patient's demographics, that is the patient's name, the patient's hospital number, the patient's address from the HIS. And also, sometimes if the HIS is enabled with electronic requests, then the HIS can send electronic requests instead of a paper form to the RIS and thereby interact with the PACS. So the HIS does not interact directly with the PACS, it interacts through the RIS. Now the RIS refers to the radiology information system, and this system manages all the non-image data of the PACS. So the PACS handles all the image data, the RIS handles all the non-image data. So the RIS holds all the radiology specific patient data from patient scheduling information to the radiologist dictated and transcribed report. So the RIS can be even used to create an electronic request in the absence of a HIS. So it can create a request on its own, or it can get a request from the HIS and transfer it to the modality. Now, the RIS can also create work lists for each modality, a CT or an MRI, by assigning the request to the particular modality. And the RIS also helps in creating reports. For this reason, we can store report templates in the RAS so that it is very easy to use the templates and create the radiology reports whenever necessary. The RAS also stores the radiologist and technician credentials because this is important for security. So the username, the details of the radiologist, the password of the radiologist is all stored in the RAS. And this RAS communicates to the HIS and also to the PACS. So the RAS is the intermediary between the HIS and the PACS. So this is a simple representation of the PACS architecture. We have all the digital image modalities, the fluoroscopy, the MRI, CT, ultrasound, and computer radiography. And all these images are routed to the archive where the images are stored either directly or after post-processing in a post-processing workstation. From this archive, it can be accessed to the diagnostic workstation with the radiologist uses or the clinical review station with the clinician uses, or it can be accessed even remotely off-site through teleradiology systems. So this network of the PACS and the RAS interact. All this happens through the local area network cable. Now, in order for the HIS, the RAS, and the PACS to interact smoothly, they all should conform to the HL7 standard. The HL7 standard oversees most clinical and administrative data such as demographics, reports, claims, and orders. And as with DICOM, HL7 is composed of many parts and used at many levels within the various hospital systems. So it is a standard which is generally used in communication between the HIS and the RAS. So the HIS has to be HL7 compliant and the RAS has to be HL7 compliant, and both of them will communicate through a HL7 server. If all this is ready, then we are ready to view images in the PACS. For this, we need a appropriate computer with a reasonable resolution monitor. And nowadays, most PACS use web browsers to enable easy access of the images. So, what is the advantage of using a web browser enabled PACS is that no separate installation of any specific software is needed. One can use the routine web browser that is available in the PACS to access the images in any location. Because of the web browser facility, physicians may even access the PACS in their personal computer or even tablet or even smartphone at virtually any location, and sometimes it can be enabled even off-site from their home also. They can access. This is especially important for emergency radiology viewing. Now, a PACS that is being established along these standards has many advantages. It eliminates the traditional film libraries and the inherent problem of physical space requirement for the hard copy images. It is particularly difficult to maintain films because they tend to get stuck to each other and to the covers for long term, and there is a lot of deterioration, and retrieval of the images is very difficult. So this is a specific advantage of PACS over traditional film libraries. Also, the rapidity of transfer of images within the hospital is a unique advantage of PACS. This cannot be even imagined with traditional film libraries where the film has to be physically transported from one place to the other. This is especially important in operating rooms where during the operation the clinician or the surgeon has ability to view all the images that are available for the patient from the X-ray to the MRI. Also, there is the convenience of searching and retrieval of images. So the name or the patient number or the date can be used to easily retrieve an image from the PACS. So the elimination of misplaced, damaged or missing films is a unique advantage of PACS. There is a very remote chance that image will get lost in the PACS. So the PACS does this, that is, it replaces the film room. We can see that the films are all stacked like this, and it's very difficult to physically search and retrieve a particular image. The PACS replaces this. The PACS also replaces the reading room. That is, initially radiology areas used to have large viewing boxes where films used to be mounted like this, and then only reporting can start. So this awkward arrangement has been placed by the PACS, and it is a very important advantage of the PACS. The other advantages of the PACS are consulting outside specialists. For example, we need a specialist opinion from another hospital, then through teleradiology, the images can be transferred and the interpretation can be obtained. Also, simultaneous viewing of images at multiple locations in the hospital. Initially, in film-based solutions, there used to be one film and it can be viewed at only one place. Whereas in the PACS, multiple copies of the images are available and they can be viewed simultaneously at multiple locations. This is a unique advantage of the PACS. Also, there is an increase in efficiency of reporting when we use soft copy images instead of hard copy images. Because with hard copy images, the filming is done by the technician and many times some important images may be missed. Whereas with the soft copy images available in the PACS, all images are available with the radiologist. Because of that, multiplanar viewing is possible, electronic annotation is possible, and windowing can be changed either to bone window or lung window to suit the viewer's requirement. Also, there is an option to include specialty image processing in the PACS. This may be added to the PACS as and when necessary. This is especially important when we start doing coronary CT, cardiac MRI, and PET CT because fusion is required in these cases. So, all these can be done as an added facility in the PACS. Also, there is a reduction of the health and the environmental impact associated with chemical processing. When we used to use films, there used to be chemicals that are involved in processing, and disposal of these chemicals was a difficult and tedious process, and that has been removed completely with PACS. So now that we have learned the fundamentals of the PACS, three fundamental parts of the PACS are: one is that there should be digital acquisition. All the modalities have to be digitized. Second is you need specialized workstations to view the PACS, diagnostic workstations or the clinical review station, and the storage is in the archive server. So these are the three important parts of the PACS. We'll see little detail about these parts and also learn about how we establish these in JIPMER. Now, digital image acquisition in modern radiology, most images are acquired in digital format and can be transferred via a computer network. Ultrasound, CT, and MRI and nuclear medicine have been digital since inception. So there was no problem in integrating these modalities. But general radiography has become digital only with the advent of computerized radiography and digital radiography. So, and this has been a slow process and it is yet to take place in many areas in our country. Since digitization was the essential step, this was the first step that was done in JIPMER, and our CT, MRI, and ultrasound were DICOM compliant and PACS ready, and hence only the configuration was to be done, and they were readily communicating with the PACS. Whereas the X-rays, we were still using films, and PACS was installed, so we had to convert to CR and DR. We had one computerized radiography which was installed in 2010. We acquired 5 more in 2012 and 2013, and this made the radiography totally digital. In addition to that, to cater for the increasing patient load, 2 more dual detector DR systems were installed in 2015, 2 single detector retrofit systems in 2018, and with the COVID pandemic, 2 mobile CRs and 2 mobile DRs were acquired in 2020. And as of now, these systems cater to the increasing patient population in JIPMER. Coming to the second part of the PACS, that is the display workstation. The display workstation is any computer that a healthcare worker can use to view a digital image. And this is the most interactive part of the PACS. And the display station receives images from the archive. From the archive, the workstation receives the image and presents it to the radiologist for viewing. Now, these workstations can be of 2 types. One is the clinical review station, which is a simple computer. It has the PACS application software and allows the user to perform minor image manipulations to optimize the image being viewed, like windowing and multiplanar reformat. So this is a limited view workstation which is available for the clinicians, whereas the radiology workstations have advanced software to perform more complex image manipulation techniques, and these are available with the radiologists. And usually the radiology workstations are high resolution monitors, usually in the range of 3K for radiography and 5K for mammography. So this is how a radiology workstation looks like. There are 2 high resolution monitors and 1 low resolution monitor for the typing of the report. This is for viewing of the image. And as of the radiology workstations in JIPMER, we had 8 3-monitor workstations in 2013 with the inception of. We acquired 3 more single monitor workstations in 2018 and 4 3-monitor workstations in 2019 in order to account for the increasing resident population in JIPMER radiology department. The third and most important part of the PACS is the archive server. The archive server is the virtual file of the PACS. This is where all the images are stored, and it is composed of 3 components. One is the database server or the image manager, which manages the image data. And the second one is a storage. One is a short-term storage and a long-term storage. And the third one is a computer that controls the PACS workflow, where to send the image and where to receive. This is called the workflow manager. So all these are the components of the archive server. The archive serves as the central hub that receives and stores all images before being released to the radiologist for interpretation. So these are the 4 components. One is the database server, another is short-term and the long-term archive, and this is the workflow manager. They need not be separate machines. In fact, in JIPMER, all these are running in one machine, and they are divided by using VM software, that is virtual machine software. Now, about the installation of PACS in JIPMER, this was installed in 2013. Both the RIS and the PACS were installed in 2013. Before 2013, we had the disadvantage of film libraries. That is, we had only one film copy. It was difficult to store it and transport it physically from one place to another. Retrieval was even more difficult, and the making of academic use copies was also tedious. All this changed with the inception of PACS. Initially, we started with a 20 TB storage, that was mirrored storage. That is 20 TB, 2 storages were available, which were mirror images of each other. And we have worked with around 120 GB RAM in the entire archive server in 2013. This was upgraded thrice in 2017, 2019, and 2022. And at present, we work with 50 TB mirrored storage and around 400 GB RAM. And we generate images at the rate of around 4 terabytes per year. That is the present requirement of storage. So the progress has been that we became, since the inception of PACS in 2013, we became filmless in 2015. We print films only for medical legal cases. And paper requisition was there till 2020, and it became electronic requisition with the availability of electronic requisition in HIS from 2020, especially with the COVID pandemic going on. And during this time, we also installed a mini PACS with advanced multimodality post-processing for MRI for radiology reporting in 2017 and 2018. This was done to reduce the load on the long-term storage of PACS due to the fine slices from CT. So our arrangement looks like this. The CT produces images. We reconstruct both thin sections and thick sections. Sections only are stored in the PACS with long-term storage, whereas the thin section data is stored in the mini PACS, which is a short-term storage, and usually gets deleted by 5 to 6 months. And both these archives, the mini PACS and the long-term storage in the PACS, are accessed by both the radiologist, can be accessed by both the radiologist and the clinician. And the advantage of having the advanced post-processing mini PACS is that it is capable of giving specific complex reconstructions that are required in case of coronary imaging for vascular reconstruction, and for dual energy CT imaging for iodine density calculation. The MRI multimodality advanced post-processing mini PACS allows us to do diffusion tensor imaging for fiber tracking in the brain, and also for MR perfusion in the case of stroke. So from this, we have turned into this, that totally digital storage, and this is the server room. So again, coming back to the advantages which we specifically experienced in JIPMER due to the PACS is that the availability of the web browser based viewing. So there is one PACS in JIPMER, and it covers the entire campus. So from any computer in the entire campus, the PACS can be accessed through any a web browser. And it can also be accessed through tablet PCs and cell phones. Concurrent viewing by 100 clinicians is possible. This is possible because we have a load balancing which is done through 3 IPs. Though the access is done from a single IP, it's distributed via 3 IPs so that overloading of any particular IP doesn't occur, and 100 clinicians can concurrently view the images from PACS. And easy parallel viewing of follow-up cases is possible with synced viewing of slices. Especially this is important in oncology and neurosurgery, where RECIST criteria have to be applied, and whether it is stable disease or progressive disease has to be decided. This parallel viewing is of especially a good advantage of PACS. Also, we were able to create case collections for academic discussions because all the images right from 2013 to 2022 are available with us. So various case collections can be created for academic discussions. Also, it is enabled retrospective research because of the availability of a large amount of image data. And the single most important advantage is that the loss of images is extremely rare and only happens if it has not been pushed to the PACS due to some problem with the network. There have also been some disadvantages which we should take account of. One is the cost, and the cost is initial and recurring. The initial cost is with respect to buying the servers, the workstations, the monitors, which are especially costly, and the networking and the uninterrupted power supply that is required. The recurring costs are with respect to the upgrades that are necessary, the AMC contracts that we have to put to maintain all this hardware, and the loss of support for hardware. So even though the hardware is working, sometimes the original equipment manufacturer will not support it after 6 years. So we'll have to replace it. So this is the recurring cost that is associated with PACS. So there is a need for a reliable network when you use a PACS. If network is down, it means the PACS is also down. So the network switches, the networking has to be maintained well, and it incurs expense. Also, the requirement of an uninterrupted power supply is important. Though a UPS is available, sometimes because of electrical switch shorting, power can get lost to the server, and we can have shutdowns for 3 to 4 hours before we can reboot the PACS. So all this requires maintenance, and this involves expense. Also, there is a very rare danger of loss of data through server failure. Though it is very rare, this is possible. This can be obviated by mirrored storage, which is there in JIPMER, and also it can be obviated by remote site storage. That is, one storage can be kept on site, and another mirror storage can be kept off site. This is being planned in JIPMER. And also, we have to take in account the increasing volumes of studies. Though the storage volume of PACS has been increased year after year, still the amount of data, image data we are generating with and MRI has also been increasing year after year, especially because of the availability of finer slices. This is especially important with cardiac imaging, and also because we are now doing dynamic studies, multiphasic studies, that is arterial, portal, and delayed phases, and dynamic contrast with maybe 15 or 20 phases of contrast which we trace. All these generate a lot of image data, and even though the PACS storage capacity is increasing, this is being eaten up by the larger volume of study. So these are the specific disadvantages. So we have gone through the basics of PACS and what was our experience in JIPMER, and what specific advantages and disadvantages that we felt during the installation of the PACS. Thank you for your attention. I can take any questions if they are there.